Greetings. My name is Elizabeth Asige, physiotherapist from Uganda. I am the PhD student in Akwenda Intervention. I coordinated the implementation of Akwenda Intervention in the districts of Iganga, Mayuge, Eastern region of Uganda. Thank you.
Greetings. My name is Gillian Saloojee. I'm a physiotherapist based in Johannesburg, South Africa, and I was responsible for the training, support, and mentoring of the therapists involved in the Akwenda Intervention Program. In this podcast, we would like to discuss our latest paper on the Akwenda Intervention Program. This program was implemented in Uganda over the period of 1 year. 100 children and young adults with cerebral palsy between the ages of 2 and 23 were randomized into 2 geographical groups. The intervention group met twice a month. The first session each month was the caregivers only, whilst the second session involved both the caregivers and their children. The Akwenda Intervention Program comprised 5 elements. The first, caregiver-led workshops. Second element, therapist-led group sessions. The third element was the provision of technical assistive devices. Fourth element was goal setting. And finally, a communication and advocacy component. We have already published 2 papers describing the outcomes for the children and young adults in the intervention group. Our results demonstrated an increase in social function and self-care skills with a decreased need for caregiver assistance and a dramatic improvement in participation, attendance, and involvement. In this paper, our focus is the caregiver-related outcomes. The measures we used to assess this were caregiver knowledge, using a knowledge test specifically designed for the study, caregiver skills, which were assessed via a pre- and post-video, caregiver psychosocial function, as assessed by the PEDS-QL Family Impact Module, and finally caregiver stress, as measured by the Zimbabwe Caregiver Challenges Scale.
Yes, we measured the caregiver knowledge, and as shown at baseline, there was high-level knowledge that could have resulted probably from the old cohort that was followed for several years in several studies. However, at follow-up, the caregivers in the intervention knowledge significantly increased with a mean of approximately 5 versus 1, the control group. This showed a significant increase in knowledge after the intervention for the intervention group. We also looked at the caregiver skills, where we took 3-minute video of a caregiver feeding, dressing, and undressing the child. These videos were scored according to the project developed scoring sheet as shown, and these videos were assessed by 2 assessors blinded to group allocation and also not aware of which video belonged to the baseline or evaluation. Looking at the caregiver skills, realized that there was a significant difference between the intervention group and the control group. And this was highly driven by change in acknowledging signals, and that is communication between the child and the caregiver. In feeding, we also recorded a difference between the intervention group and the control group, but it also was due to acknowledging signals. That means that the intervention improved the communication and the understanding between the caregiver and her child. during these activities. Caregiver psychosocial functions. Like Dr. Gillian said, we use the PEDSQL, and at baseline, there was no significant difference, but during the evaluation, we realized that the psychosocial functioning of caregivers was higher for the intervention group compared to the control group. When we looked at the caregiver stress, realized that the intervention group had a very significant decrease in the caregiver stress compared to the control group, that actually the stress burden increased significantly. Looking at the results, you realize that the level of caregiver functioning in everyday life directly influences the outcome of the child. So, high level of knowledge on the condition of the child, skills on how to help the child, improve the skills on how to help the child. Like we realized that most of these skills were driven by understanding each other, the communication between the child influenced the child outcomes. And also, when you realize that dropping the stress of the caregivers was basically knowing the condition, and also during the meeting, during the Akwenda training, caregivers met twice a month and they brought their children once in a month. So when they met together, there was peer support, there was acceptance because they realized they are not alone, and other friends of theirs have children that are either better than theirs or worse than theirs. And this was a consolation and acceptance that you are not alone. Like we have all observed, the caregivers attending the Akwenda Intervention Program were more knowledgeable, had improved psychosocial function, and were less stressed. This participatory caregiver program serves as a model for improving lives of children and their caregivers in low-resource settings in any country around the world.
And it is our hope that what we have learned from the Akwenda Intervention Program can be shared in many more settings in order to improve the lives of children and young adults with CP as well as their caregivers. Thank you all.